Nakikita ba nila tayo? Paano tayo nakikita? Sige, ayos ko. May music pala. Music pala. Ayos ko music. Yun na, ayun. Nakikita ko sila dyan. Nakikita namin sila. Hello. Uh, hot, hot. Hello.
I think we can hear you. Perfect.
Everybody hear me, those who are online.
I can. Yes, I can.
Hello. Mic
I
test.
can hear you clearly.
It seems that they can't hear us.
Yeah, well, I'm hearing everyone. Hi, this is Dr. Edo. So I can hear everyone, but Chris, you're coming in a bit weak from your side. Maybe put the microphone closer to you because everyone else online is quite clear.
Am I clear now?
Yes, I can hear you clearly.
Okay. We would just like to ask permission from those who are attending online if we can do, if you will allow us to do a Facebook Live. If not, that is okay. We'd like to hear from everyone.
Yes, please.
That's fine with me.
Yeah.
Doc Edhel.
That will be fine, although I will be discussing some patient experiences, so I'm a bit worried about broadcasting Facebook Live. I guess it depends on the goal of the discussion.
Okay. Doc Gerard.
I'm okay lang, Chris. Thank you.
Camille. Camille.
Thank you.
Okay. So I guess Miss Jessica and Dr. Dan would.
Yes, I'm good. I can hear everything. Thank you.
Okay. So,
Yes.
Dr. So what do you think?
Yes, that sounds fine. Thank you.
Doc Edhel, so what do you think? Can you slightly modify or?
I mean, it's anonymized, so maybe it should be fine.
Okay. So So we'll just start with the prayer for tonight that will be led by Miss Diane De Silva.
Okay, let us pray. Almighty and loving Father, Creator of heaven and earth, we praise you and adore you. You are the King of kings. We humbly ask your forgiveness for our sins. Have mercy on us, O Lord. We are gathered here today for our meeting. Send us your Holy Spirit to be our guide and give us the wisdom to understand every topic that we are going to discuss. Enlighten our minds and let your love be upon us. May this meeting bring success and growth to our team. We thank you, Father, for the precious time that you have given us. All this we pray through our Lord Jesus Christ. Amen.
Okay, so good evening to all. So I'm Chris Munoz from the Yellow War Society Philippines. So let me first introduce our participants for today. Joining with us online is the representative of Congresswoman Dr. Anyor Cristina Puyat Bondok, her staff, Ms. Reina Suniga.
Hello, good afternoon.
Good afternoon. Dr. Jose
Yes.
Gerard Delemac, Program Manager of
Yes.
HIV, AIDS, STI, Hepatitis at the Department of Health.
Gandang gabi.
Ms. Camille Balajay, Senior Health Program Officer at the Department of Health. Is Ms. Camille online? Okay, Dr. Edhel Tripon, past President of the Hepatology Society of the Philippines.
Magandang gabi po. Good evening.
Dr. Dan Wu from the London School.
Hello, everyone. Nice to meet you here. Thank you.
And Ms. Jessica Hicks from the World Hepatitis Alliance.
Hello, everyone. Lovely to meet you.
So here with us on site is Dr. Clark Cairo, Program Manager for Cancer at the Department of Health. Dr. Felix Labanda Jr. from the Bureau of Working Conditions at the Department of Labor and Employment.
Yes, thank you. Good evening, everyone.
And Sir Jem Cabreros, member of AIDS Society Philippines.
Hi, yes, good evening, everyone.
And Mr. Patrick Saborit, President of Yellow Wire Society Philippines.
Good evening, everyone.
So we also have our officers and members of the Yellow Wire Society Philippines at the back. So on behalf of our organization, I would like to thank you all for sparing your precious time for this roundtable discussion, which is centered on ensuring non-discriminatory practice on people living with viral hepatitis during pre- and post-employment stage. So now I would like to invite our partner, Ms. Jessica Hicks from the World Hepatitis Alliance to give the opening remarks.
Thank you. Thank you very much, Chris. And thank you to the Yellow Warriors Society Philippines for partnering with the World Hepatitis Alliance and London School of Hygiene and Tropical Medicine to convene this important meeting and working with us on our broader project that Dan will speak about. You know, stigma and discrimination continues to be such a significant global barrier to elimination. And so really excited to be joining you today to discuss what's happening in the Philippines to address this, and really looking forward to the conversations today and looking from the Alliance perspective how we can take some of the learnings and disseminate that to our broader membership. So I know that we're short on time today, so I will pass over to Dan and just finish by saying Happy World Hepatitis Day to everyone.
Thanks, Jess. It's a nice opening. And can I share screen? I think I can. Can everyone see my screen now?
Yeah, it's
Can you-
good. Thanks.
Okay, great. So I would like to just introduce a little bit to what we have done in these why we're now working with Chris and Yellow Warriors on this. So this basically is because there are a lot of advocacy and patient efforts happening around the world, but many of these enormous and wonderful patient efforts or advocacy efforts are not seen. So that we organized in partnership with World Hepatitis Alliance, the London School team has organized a global open call to solicit stories from all over the world about the patient and advocacy efforts in fighting against chronic viral hepatitis. So this is a brief introduction to the global open call, and very briefly about the need, like worldwide, you might be very familiar with this, like worldwide, over 354 million people in the world are living with viral hepatitis B and C. And I know that in the Philippines, there's also a high prevalence of Hep B and Hep C. Like 1 in 10 people in the Philippines are living with HBV, and 6 of 1,000 have HCV. And in China, we have the same high prevalence burden of HBV and HCV. So I think both countries have some shared challenges in terms of tackling HPV and HCV, but this is not just 2 countries. I believe it's a global issue out there. And as I mentioned, many of the patient advocacy efforts are not seen. They are powerful stories and tools to fight against these 2 chronic diseases, but they are not often seen by many people. And so we organize this global open call. The overall purpose is to understand or to solicit stories related to lived experiences and advocacy with viral hepatitis. And we particularly look for personal or family stories about living with hepatitis and advocacy experiences. So we asked for submissions in the format of images, videos, audio files, and written stories from the audience worldwide. And in total, we solicited 119 stories, and 85 of them are relevant to the topic. And there are a lot of excellent entries from worldwide, including those from Chris' group, the Yellow Warriors group, and 29 of them are determined a finalist. And we found that among all these finalists, 47% of the submissions reported some lived experiences of hepatitis, and 62% reported having a family member or friend living with HPV or HCV. So you see that many of the advocates are having some sort of experiences of living with HPV and HCV. And we did an in-depth analysis of those submissions, and we found that the advocates and patients are playing huge roles in terms of changing the local paradigms of chronic viral hepatitis health services in local settings. Like, for example, across the whole hepatitis care continuum, they played essential roles in increasing testing and increasing linkage to care among people who are diagnosed with hepatitis B and C. And then they also help improve treatment uptake by promoting referral to care or healthcare services in local settings. And they also sort of normalize care seeking experiences along the care continuum. Many people also advocate for anti-discrimination or anti-stigma after they get cured and by sharing their own stories. So it's really important to see what advocates or what patients are doing in terms of improving people who are having the similar experiences affected by viral hepatitis worldwide. And I think one of the most important things that we have identified is the anti-discrimination practices worldwide and laws against testing. For example, for school and work has been, it's an important issue, important thing to in terms of eliminating hepatitis, but it took us more than a decade. For example, in China, it took us nearly 15 years to pass the bill, and lots of efforts and times and patience to go through the whole journey. And nowadays, we have the laws in place. There's still a lot of challenges in enforcing the laws. Like, for example, many organizations or educational institutes, workplaces, they're still asking for hepatitis testing for schooling or work. But with this law in place, many organizations, like community organizations, they are able to use the laws as a powerful tool against such unlawful practices. So this law in place is really valuable. It's not because it's just a law, but because it's there's right and care in it. So in summary, I think it may take years or decades to pass bills, but I believe we'll get there with all of our efforts and ambitions to fight against hepatitis. Thank you everyone for your attention. I'll stop there.
So thank you, Dr. Danu and Ms. Jessica. So we would like to start the presentation from Dr. Gerard Belimac from the Department of Health to give us a current implementation of the hepatitis B and C treatment in the Philippines.
Good evening, Chris. Please confirm if okay ang audio ko and my slides are readable, are on the screen na.
Yes, very clear, Doc.
Thank you. So good evening, everyone, and good morning and good afternoon to all our partners in this call. My name is Dr. Gerard Belimac from the Infectious Disease and Adult Health Division of the Department of Health. So today, I'll be sharing with you some information on the implementation of hepatitis B and C treatment in Philippines. No? And but I will start my presentation with a brief some information on the reactivities of testing that is being done nationally. And then second is, what are the policy provisions pertaining to hepatitis B and C in our national policy guidance? And lastly, the activities that are being implemented by the Philippine Department of Health. So as you see in this slide, you see here that we're testing about 1.1 million tests in 2020 across the country, and the reactivity rates of this testing is so far between 3 to 4% reactive among 1.1 million tests done in 2020. And this report is being obtained from our public and private testing laboratories. That's for hepatitis B. And for hepatitis C, the total number of tests is a bit lower at around 219,486 tests in 2020. And the limitation of this data is it could be a duplicate. No, some people may undergo twice tests, two tests per year, because this can also be obtained from our um, blood service facilities as well. And the reactivity rate for hepatitis C in 2020 is between 1 to 3%. So what has the Department of Health, our Bureau has so far done in terms of screening, diagnosis, and treatment? Of course, our track in the Disease Prevention and Control Bureau is develop policies that would set that would influence the practices of health services in our health centers. No, the smallest health facility is being influenced by our national policies. And secondly, we also conduct service delivery activities to augment the services of our implementing agencies. So far for our policies, and this is freshly finished and disseminated, there's hepatitis provisions in the Omnibus Health Guidelines per life stage, and I will discuss later what are the contents of these Omnibus Health Guidelines pertaining to screening and vaccination for hepatitis B and C in my next slide. And also, as a country, the Department of Health did collaborate with our Department of Science and Technology, and this is being our implementing partner is the Hepatology of Society of the Philippines, where the clinical practice guidelines on hepatitis B and C was developed in 2019. No? However, the society has expressed to their interest to review further the content of the hepatitis B and C clinical practice guidelines. As to service delivery, we only have started introducing a formal screening and treatment program as a pilot demonstration project in 2019 in selected subnational offices in the country. No? So we implemented this in 3 big regions, Region 3, Region 7, and NCR. And so far, only Region 3 have generated a well-documented pilot demonstration in 2019. And with the positive output or outcome of the pilot demonstration, the screening, diagnosis, and treatment interventions were subsequently expanded, and we had a national rollout early in 2020. And with this screening, diagnosis, and treatment strategy, the Department of Health provided the commodities and medicines for hepatitis B and C treatment for those who are eligible of the medicines. So what is the life stage Omnibus Health Guidelines? So let me talk shortly about life stage Omnibus Health Guidelines. Sorry, this is of course an error on my part. The Department of Health is now working towards integrating our work, and so we do not issue standalone policies and standards anymore, so that our implementers are not confused of the multifarious issuances that we are giving them. So instead of having standalone or vertical policies, we try to incorporate all policies that we have. And of course, this is based on the burden of disease as a matter of prioritization. So the Omnibus Health Guidelines are list aggregated into life stage, and the different life stages are the newborn, the child, the adolescent, adult, and the elderly. So these Omnibus Health Guidelines will also become our advocacy tool to our national health insurance program, so that our national PhilHealth will also adjust their benefit packages based on the the services that we would want to see in the health centers as defined in these omnibus health guidelines. So let me just enumerate that for the newborns, we have defined that hepatitis B vaccine should be given, and the subpopulation targeted is those who are less than 24 hours of age. And then for the child, these are the vaccines that need to be administered. And these are the subpopulations: all infants less than 1 year old and 13 to 23 months old in catch-up vaccinations in many facilities, and children with HIV, and all children equal to or more than 1 year old. For the adolescents, we have vaccination, and these are the subpopulations, and also screening tests for hepatitis B and hepatitis C. No, again, these are the subpopulations. It goes the same with the adult population, where these are the vaccines to be administered and are indicated, and these are the subpopulations. And of course, the elderly. The elderly will be given medical advice and access to screening, testing, and treatment if they are found to be vulnerable to the two viruses. Again, these omnibus health guidelines will be defining the basic services that the public health, the primary care facilities in our country should endeavor to provide to our fellow men. For in terms of hepatitis B and C treatment, as mentioned, this is already on a national scale up. And in our national scale up, many facilities are identified to be dispensing units of hepatitis B and C treatment as well. But the blue facilities here are actually our HIV treatment hubs. No, we identified in that issuance in 2019 the HIV treatment hubs because the HIV we feel that there's no much capacity building and systems development to be given because these are already existent in these treatment hubs, and in the treatment hubs as well, because they are well trained on handling patient confidentiality because these are HIV treatment hubs. Then it's just a matter of expanding the disease, the infections that they will be clinically managing, and notwithstanding their existing skills and capacity to address stigma and discrimination in the workplace. The red facilities are the primary care facilities or outpatient clinics, no? And these are the numbers are smaller compared to the HIV treatment hubs, which are primarily hospital-based HIV clinics. And also, we have a directory of healthcare providers that are trained with our simplified screening and diagnostic and treatment protocol of the Department of Health. And the trainings of our clinicians here are being provided by the Hepatology Society of the Philippines. And for the commodities, we have a law that mandates that the national health system should really start to implement decentralization of procurement of commodities. And in this slide, you will see that for HIV and hepatitis commodities, this will be the commodities that will be decentralized for a local government procurement in the subsequent years starting next year, year 2023. So the local government units will be expected to provide, to procure these B and C test kits. And of course, they are expected to clinically manage patients eventually diagnosed with chronic B and C hepatitis. So all in all, this will be the summary of my presentation based on laboratory reports from public and private facilities, including blood banks. The reactivity rates of hepatitis B is 3 to 4%, and hepatitis C is at 1 to 3% among those who were screened. The DOH, Disease Prevention and Control Bureau, has recently issued the Omnibus Health Guidelines across life stages. These Omnibus Health Guidelines will become basis for the implementation of health services at the primary care facilities under our Universal Healthcare Act. Number 3, a range of screening and vaccination guidelines for different life stages are enumerated in our Omnibus Health Guidelines already. Since 2019, facilities and healthcare workers across all levels of care had been capacitated on the screening, prevention, diagnosis, and clinical management of people with hepatitis B and C. Number 5, hepatitis B and C screening and treatment are included in the commodities for distribution by the Department of Health in 2022. And lastly, a brief mention of our Universal Healthcare Act. The provisions in the Universal Healthcare Act can sufficiently enable the health sector to deliver comprehensive health services to all Filipinos. So I guess with this slide, I would end my presentation and thank you for your attention. Magandang gabi po sa inyong lahat.
Thank you, Dr. Bellimap. So we'll just have a few questions later. Next is Dr. Clark Cairo. We'll discuss an update on the liver cancer program.
Okay, so happy Thursday, everyone. I'll be giving you updates on the liver cancer control program as part of the National Integrated Cancer Control Program. Next, please. So based on the WHO Global Cancer Observatory in 2020, among Filipinos, liver is the 4th most common cancer, and it's the 2nd leading cause of cancer deaths, next to lung cancer. That is why liver cancer is one of our top priorities for the cancer control program. Next, please. So this slide depicts NICA, the National Integrated Cancer Control Act, or the Cancer Law. Its purpose is to close the gaps and address the inequities along the cancer control continuum. So when we say continuum, that is from the primary prevention until the end of life care or hospice care. So we have these 4 phases to implement the law, because we will do it in phases. So phase 1, from 2021 to 2024, it's starting up. And phase 2, 2025 to 2027, strengthening the program. And phase 3, 2028 to 2030, scaling up. And finally, phase 4, beyond 2030, that is to sustain and continue the improvement of the cancer control program. For the access to primary prevention, so we will establish that in the 3 settings, like the community, workplace, and schools. So when we say access to primary prevention, we are talking here of the healthy population. So that's the majority among population. And access to early detection, we're talking here of the at-risk population. So that's with the risk factors to get the cancer. And also it's settings based. And for the sick population, those with cancer, we will provide access to complete diagnosis. We need to rule out metastasis. That's part of the complete diagnosis. And we need to provide them access to optimal treatment and care via multidisciplinary team. So cancer is always managed by a team, not just by a single oncologist. It's always a team of professionals and different oncologists. So for liver cancer, of course, when we say access to primary prevention, we're dealing here with the healthy lifestyle campaign. So we have to promote vaccination, particularly hepatitis B vaccination. And then access to early detection, the screening tests will come in, especially in the workplace for our employees as part of the, maybe a part of the annual physical exam, if it's part of the policy, company policy. And then if positive for screening, then the employees will need to undergo further workups. So they need to complete the laboratory tests. And then, of course, if really positive for hepatitis, then they need to undergo treatment, complete treatment and care. So we are also prioritizing cancer registry because right now we're using the population-based cancer registry. So it's under the law, we have to establish hospital-based cancer registry so that we can really get the complete picture of our cancer patients. We can disaggregate the demographics, let's say, among liver cancer patients who really are at risk in the Philippines. So is there an incidence of aflatoxin-associated liver cancer? Or what's the really, what's the incidence of hepatitis B-associated liver cancer in the Philippines, like that? And patient navigation, it's always hospital-based. Actually, the patient navigators is also under the Universal Healthcare Act, will guide the at-risk population from access to early detection until the availability of treatment and care. And finally, we will always fund the research and development. As you know, we lack the local studies. We are always dependent to international studies. So it's about time that we will pursue local researches. And our vision is cancer-free Philippines. Philippines free from the burden of cancer. Our mission, people, patient, and family-centered healthcare system, delivering accessible, equitable, and inclusive quality cancer control services. And our goal by 2030, at least 50% of all Filipino cancer patients will have equitable access to comprehensive cancer control services, thereby reducing by 10% the overall mortality from cancer. So the cancer control program is aligned with the viral hepatitis program and their global call to action to eliminate hepatitis by 2030. Next, please. So what's in it for the patients under the cancer law? So we have this assistance to the patients and persons living with cancer. So for PhilHealth, they have the case rate already, and the Z benefit package for liver cancer is still a wish list. Hopefully, with the CPG in place, they can fast track the development of Z benefit package for liver cancer. And Consulta package is an outpatient package wherein they can, the PhilHealth can develop, let's say, all the diagnostics for liver cancer, including the hepatitis B screening tests. And for the DOH, from the cancer control program, we just launched last year the Cancer and Supportive Palliative Medicines Access Program, or CSP MAP, wherein we provide free medicines medicines for cancer, supportive care, and palliative care to our patients. And it's available in 31 access sites across the country. And for this year, it's part of the General Appropriations Act. We have this budget amounting to 529 million pesos to be given to our patients in need of assistance for the diagnostics and some therapeutics. So the guidelines is still for finalization together with the Department of Budget and Management. Hopefully this third quarter, it will be out and we can sub-allot the budget to our access sites where our patients can avail of additional assistance, not just for free medicines under CSP map, but for, let's say, cancer control assistance program, they can also avail additional financial assistance on top of PhilHealth and Malasakit centers. So for Malasakit centers, they have a separate Republic Act. According to the law of Malasakit centers, the patients, the indigent, and even the financially challenged patients can avail free diagnostics and therapeutics. Although not completely free, but a portion of the expenses because of the limited budget. Not all patients can be covered. I mean, they prioritize the assistance to be given to our patients. Of course, not just for cancer, but for all patients. And finally, for others, we will include here the Philippine Charity Sweepstakes Office, the Department of Social Welfare and Development, other non-government organizations, philanthropic foundations, and other stakeholders where they provide other assistance for the diagnostics and therapeutics of our patients. Next, please. And we would like to inform our patients that they have this privilege under Section 25 to 27 of the Cancer Law that all cancer patients and persons living with cancer, including cancer survivors, are now considered as persons with disability. So in the form that you can see on your right, the type of disability will be the cancer law itself, Republic Act number 11215. And what is that? The cause of disability is chronic illness. So the training on the implementers in the LGUs is ongoing. We are being assisted by the National Council on Disability Affairs and the Department of Social Welfare and Development in this huge endeavor. Next, please. And here are some initiatives of the Cancer Control Program in partnership with all the stakeholders. So number one, we just developed the clinical practice guidelines for liver cancer or hepatocellular carcinoma. This is a first of all cancers to have a local CPG. And it's already being disseminated to all stakeholders. Next is the conduct of the yearly liver cancer and viral hepatitis awareness campaign together with the Hepatology Society of the Philippines, of course, the Yellow Warrior Society of the Philippines, and organized cancer screening where liver cancer is included. So hopefully before the year ends, we can disseminate this manual of operations, procedures, and standard. And lastly, we will provide technical assistance in the development of cancer control policy in the workplace, which is included in our cancer law, so that all our employers can be guided on what to include, what benefits they can provide to their employees. So I think that's all for my talk. Thank you very much.
Doc Adele.
Hi, Chris. Is it my turn?
Yeah, yeah.
Okay, so let me share my screen. Is my audio good?
Yeah, you're good.
Okay. Let me. Can you see my screen? Is it
Yes.
clear? Is my audio clear?
Yes, clear.
Hello, good evening, everyone. I'll be very brief. I'd like to thank the preceding speakers from WHA and the London School of Health and Tropical Medicine. My name is Dr. Edel Tripon. I'm representing here the Hepatology Society of the Philippines. We've known each other, the Yellow Warriors, I think for the past decade, and the talks from Dr. Bellimac and Dr. Cairo gives me that longer perspective of the past few years on how we've gone to having no clear services yet for hepatitis B, aside from infant vaccination, to hoping to roll out and cascading out a national program for access to diagnosis and treatment, and hopefully treating complications like liver cancer. Still aspirational at this point, but it's good to know that we've taken the proper steps. And like Dr. Wu said, sometimes these things really take work. It may take 1.5 decades, but we just, carry on. And my task here is to discuss how discrimination affects access to care and treatment, and give this in the way of sharing stories of hepatitis B positive Filipinos. So when we discuss living with hepatitis B through a patient perspective, this was discussed in a paper published about 2 years ago, and it discusses things like primary impacts, meaning the direct impact of a person knowing that they have the disease, chronic hepatitis B, secondary impact, which is the impact on the affected individual, the one with hepatitis, caused by the response from society. And society in this respect can be family members, healthcare providers, and whether trained or untrained, community and government institutions. And tertiary impacts are the harms associated with an affected person's response to this perceived societal stigma and discrimination. So this is that diagram from that paper. And in primary impact, you discuss the fear of disease progression when you know that you have viral hepatitis, the prospect of having financial loss, the fear of infecting loved ones, especially when you're not aware of the specifics and are not well educated about the disease. And where stigma and discrimination come from is usually the people around you, whether it be the community, even healthcare providers who are mostly, especially if the training is not there yet, whether they give wrong advice and wrong prognosis, and even in the daily life of a person as they engage in their employment, as they try to get an education or even get jobs in government or government benefits. And these tertiary negative impacts can include a patient's withdrawal from society and having perceived self-stigma and guilt, and passivity that can affect their outcomes. And I want to discuss 3 patients. They've been anonymized and their histories modified a little bit. And my hope is that after discussing these patient perspectives, maybe that this can be a jump-off point in terms of the discussion. I mean, we've discussed in terms of what we have and we might have in the near future in terms of services for hepatitis B patients and their complications, but maybe we can take a look on what we still have not been able to get a jump on, and that is really drastically modifying policy and laws to protect our hepatitis B positive Filipinos from discrimination, which, as you will see in my slides, has been institutionalized. So the first case is of a young female. She's 18 years old. She has gotten an academic scholarship in a private university for nursing. Unfortunately, for her, she was diagnosed with hepatitis B on entry to nursing school. And you know that for this patient, it was something that she acquired at birth because her mother had hepatitis B, her maternal aunt and uncle also had hepatitis B, and a grandmother, the mother of her mother, the maternal grandmother, died of liver cancer related to hepatitis B. The patient fortunately was able to enroll in a trial and in a cohort study of hepatitis B patients. And it was seen that her liver status was healthy. She was already spontaneously E antigen negative and her viral load was suppressed even without antivirals. And in the first consult that I had with this patient, I discussed, she was concerned about the discrimination, the prospect of discrimination, because she really wanted to be a nurse, but was concerned that she would not be employable and whether she would be able to finish her course. And true enough, about 1 year from the initial consult, I got an email from this patient where she discussed with me that after discussions with her counselor in this private university and her family, she decided to shift from nursing to a non-health related course because she was told by the university that hospitals will refuse to accept her for internship when she reaches her clinical years because of her positive hepatitis B result. And this is even with my reassurance that I will give her a supporting medical certificate should she wish to continue with her course. And after heavy discussions with her family, she finalized her decision and she was asking for a medical certificate in order to argue with the university that in spite of shifting to a non-healthcare related course, that she could maintain her academic scholarship. So long story short, this shifted to another non-health related course purely because of her hepatitis B status. And for the next case, we have, again, another young individual, male. He's a police corporal, a father, married with a father of 2 young children. He was diagnosed with hepatitis B. I suspect that this patient was infected as a child. However, on entry and enlistment, he was negative, most likely because of a poorly sensitive hepatitis B serology test. And he was otherwise fit, so he was able to enlist in the PNP and went up in the ranks in the subsequent years. However, in the annual physical exams that were done for his continuing to be in the force, he was diagnosed with hepatitis B, but fortunately it was already when he was in the force. So upon inquiry, I realized that hepatitis B is something that is required and investigated in annual physical exams of individuals in the police force, and even includes specific in the medical chart history, the serology of the HBsAg of the individual every year. So I never got to ask the patient whether he had to hide his positive status from these annual exams. Unfortunately, so he was more concerned about hiding his positive status because he was afraid that he would lose his position. Until late last year, he noticed some pains in the abdomen and he got an ultrasound out of pocket and that showed that he already had surprisingly liver cirrhosis and a liver mass. And shortly after, this was diagnosed to be liver cancer. So this patient now has cirrhosis, now has liver cancer. And instead of being able to use his position in the police force to try to help him subsidize his treatment, he even specifically requests that I remove hepatitis B in his medical certificates when he asks for assistance, because he is very much concerned that he would be removed from the police force. So this is our second individual. Lastly, so I have very short slides. Lastly, I have a 34-year-old young man who has 2 young children and a long-term partner. He already knew over 10 years ago that he was positive for hepatitis B. He was a previous OFW, had a mother who had been working for a long time in Dubai, and this was before hepatitis B tests was institutionalized in GAMCA countries. And his sisters were also positive for hepatitis B. He had no regular consult, no advice for his hepatitis. And his central concern about his hepatitis B was that it prevented him from working overseas in the Middle East as an OFW. And so he had no follow-ups, had a lifestyle that included heavy alcohol intake and was obese. When he noticed that in 2021, he started to lose weight. In short, he had signs of liver disease decompensation, and that prompted him to start consult. He wasn't even on antivirals at that time. And upon consulting, he already had far advanced liver cirrhosis with complications, and he was already advised to have a liver transplant. So for this patient, he's at that cusp. He knows he has hepatitis B. He has no good gainful occupation and is at the point of difficulty asking for funding for his liver transplant because of limited employability. Also in his siblings who also have hepatitis B. So now that we have the example of the 3 patients, you try and wonder how these patients lived through initially finding out that they had hepatitis B, whether they were concerned for the fear of disease progression, or they centered on the financial loss because of the relationship of hepatitis B status to the discrimination that they would suffer, losing their ability to get gainful employment. And how this affected their health-seeking behavior, and how this led to passivity in terms of consulting, especially for the last 2 individuals. And for people so young to be diagnosed with late-stage disease with no clear subsidy for advanced stages of hepatitis B complications is not easy. And this is I have to thank the DOH Central Luzon pilot site for this cascade of care slide. And here we see the cascade of care. The first bar shows us the numbers who were positive. And then there's a slight attrition in the patients who go from positive to those who were assessed whether they need to have treatment or not. And then those who eventually were assessed to be treatment requiring, and those who eventually got treatment. So you see the attrition there was actually related to bottlenecks in terms of diagnostics. For any diagnostics that were out of pocket, that were needed to assess treatment eligibility, this was where we got attritions. And you wonder now, if stigma and discrimination come into the picture, what kind of further attritions we will see. And this was a relatively well-funded program because it was done in LGUs that were quite empowered. So something that, of course, will not be uniformly implemented because when healthcare is devolved. So when you have stigma, discrimination coming into the picture, we see patients that are late stage. We see patients that are reluctant to continue care and who have different priorities. And I guess this just in summary, this is my summary slide. we see that stigma and discrimination are still vital and affect patients with hepatitis B, especially in the Philippines. And stigma and discrimination do affect healthcare-related outcomes still. And as the World Hepatitis Day motto goes, we still can't wait until that time that policies and funding are already in place and assured so that these concerns are addressed and we see less of these problematic individuals in the future. So thank you, everyone. Back to you, Chris.
Viral hepatitis getting discriminated every day. Every new patient discovered their status because they were screened, not because they were screened in a healthcare setting, but they were screened during employment. And in fact, Yellow Warrior Society Philippines started not because the group was looking for treatment, because at that time it was the treatment was for PEG interferon, and they didn't really mind the treatment. What they their status at this time. And the more actually it is it's very sad because every day we'd like to talk about or every year we talk about viral hepatitis, and we want to increase awareness, and we increase awareness for people to understand what Hep B or Hep C is all about, and that they should not discriminate. But what is happening is the other way around, that employers are more knowledgeable and they get to so that Miss Reina Suniga, the staff of Congresswoman Bondok, would fully understand what we are asking for and what we need. So next, we'd like to have a presentation from Dr. Felix Labanda Jr. to discuss why the need of a stronger legislation for people living with viral hepatitis.
Thank you, Chris. Could you flash my There you go. Are we good? Okay. Next slide, please. So for the Department of Labor and Employment, I have heard most of the mandate, and we cannot go beyond what is said in the law or what is said in the Constitution. So the department advisory has a goal of reducing the transmission in the workplace and eliminate discrimination against workers infected with hepatitis B. please be mindful that in this goal, there is already a collateral of discrimination against workers infected with hepatitis B. However, please look at the title. This is a department advisory. Notice, this is not a not. So, okay, forward. Next slide, please. So the salient features of Department Advisory number 5 of series of 2010 is that there should be no discrimination of any form. So when we say discrimination, this is based on the ratification of the Philippines of ILO C111. So this particular ratification is looking at discrimination in the workplace in all its forms. So discrimination from hiring, discrimination from promotions, discrimination from getting specific training. It would be favorable for me not to hire these workers because they have X number of probability that they will get sick later on in their work life. But there is no law against that. So then we have number 3, workers shall not be terminated on the basis of the actual, perceived, or suspected hepatitis B status. Please note that if you look at this number 3 and number 2, this is almost similar to the condition of HIV in the workplace. That is why, can you have that on the next slide, please? All right. So for the next slide, if you look at it, the management of the sick employee shall not be different from any other illness. So whether it's HIV, it's hepatitis B, it's COVID-19, it's pneumonia, it should be the same. The benefit should be the same. There is just a minor difference when we are talking about a different disease with a different mode of transmission. So for example, if it's mental health in nature, the management is a bit different, but it is still lodged with the Rule 1960 of the Occupational Safety and Health Standards, which establishes that there should be a health program for our workers. And this is the main anchor point that we have based the department advisory. Please be mindful that the Occupational Safety and Health Standards of the Philippines is lodged against the mandates of the department to set standards for the workplace, and this is based on the Constitution. So it's several layers of basis. So if you are the owner of a particular workplace, you will not look into that very deeply. You will just say, oh, it's an advisory. It's an advice. I can opt not to take it. So they will not see it as something that they should follow. However, for us, being there is several layers of requirement before we arrive at this particular juncture, we cannot say that you should do this because it is transferring from the Constitution to us to the standards and then to a program and then finally to here. So that's several layers. We are not, it's different as opposed to the mental health program, which is Department Order 208 series of dash 19 because it is based on Republic Act 11036, which is the Mental Health Act. So it's an order based on the Republic Act. So there is no it's not rocket science to get the difference. Okay. And then on number 6, there's employers should take measures to reasonably accommodate workers. In this particular situation, the particular advisory was created in 2010. However, the number 6, the reasonable accommodation of workers, for example, if they need to undergo treatment, would fall under the Telecommuting Act. And this is not specifically mentioned in the Constitution. So several layers na naman. So because of that, the reasonable accommodation may be lost in translation, meaning when you say reasonably accommodate, what does that mean? For me, the employer, am I supposed to institute the Telecommuting Act for this particular advisory? So there's a difference. There's a going to be a disconnect, especially if employer chooses order. And this is by Dr. Belly Mac a while ago, since they are into the adult diseases. Okay, but this is already treatment, and DOLE does not handle treatment. We are handling prevention, and we are handling prevention of discrimination, because again, as what Chris mentioned a while ago, the start of the fight is not because you are sick. The start of the fight is because you are sick and you cannot get gainful employment because you are sick. That is the problem. Because, again, we do not have a law that prevents that from happening. All right? Next slide, please. Oh yeah, next slide. Okay, so what is the DOLE monitor? So these values that you see, the colorful fence that you see, is actually the result of our labor inspection for the entire Philippines. On the leftmost side is the value for the entire Philippines, and then down the line would be per region. So you can see that for the entire Philippines, for the year 2021, which is colored blue, we have a 96% compliance to the policy and program on the prevention and control of HIV. I'm sorry, did you go back? Okay. Prevention and control of HIV/AIDS, tuberculosis, hepatitis B. Okay, so why are all of these diseases lumped together? These are technically all infectious diseases. Okay, I'll explain it later on. Okay, and then beside the blue line is the orange bar. This is for the year 2022, January to June. Again, it's also 96%. Relatively, you can see that what we have is a relatively high implementation of the presence of the policy and program and on the prevention and control of these said diseases. However, the DOLE cannot monitor who has what. Okay, we cannot say, oh, which company has HIV and AIDS? How many of your workers has HIV and AIDS? Because why? Because if we ask the company to already identify the workers that have HIV and AIDS, 1, it breaks privacy. 2, it promotes discrimination. Because what we're after is, regardless of my health status, I should be able to work as long as I am capable of working. Okay? So what does that mean? The compliance to having the policy and program is one thing, because you say, oh, that's just something in paper. That's just something that is written. Remember that an implementation of a program without something written in paper is prone to abuse, is prone to open interpretation by the employer. It's always the employer that is on the winning end. So we want something that is written down, something that is approved by the workers and the employers. That's why it's called a policy and program. So for those of you that are not in the know, creation of a policy and program on occupational safety and health specific for HIV/AIDS, tuberculosis, and hepatitis B requires it to pass through the OSH committee, which is required by law to have establishments to have the occupational safety and health committee. This is under Republic Act 11058 or the OSH law. The implementing rules and regulations for that is the 0198-18 has a penalty if you do not have an OSH committee. And the OSH committee is composed of the workers' representative, the employer, and the safety officer. So given that, if you create a policy and program specific for these particular diseases, then you would have the employee's voice or the worker's voice in the creation. So the discrimination, the prevention of getting the proper treatment would be incorporated. So as you can see, we have Region 1 that has relatively low, meaning this is the area where we need to focus more on promoting. So this particular data, we submit it or we provide this to the Occupational Safety and Health Center, which is the advocacy arm of the Department of Labor and Employment, because at the end of the day, we do not need the money. The penalties that we gather from establishments does not increase or does not decrease the discrimination. What we're after is the knowledge of the employers on what they should and should not do. That is why the HIV and AIDS, tuberculosis, and hepatitis B is a buy one take one, buy one get three or something like that. Because if you have something a policy and program on HIV and AIDS but does not have a policy and program on hepatitis B, then you're missing out on a component. Then most probably the policy and program is not inclusive. The same is true for tuberculosis, because HIV and AIDS with tuberculosis is a very potent killer. And lastly, hepatitis B without HIV and AIDS consideration is basically useless, or it is a half-baked cake. So it's not usable for our workers. That is why when we are monitoring it, if you do not have one of the three, then it's an X. So the 96% means they have the three. If you have 7, like in Region 1, they have, oh my God, I have poor eyesight. I think that's 73%, something like that. For 2021, it means that they have the 3, the 73% have the 3, but the remaining that is non-compliant may have 1 or 2, but not the 3. So that's the significance of this particular graph. What we're after is increasing compliance. What we're not after the money, because to tell you the truth, the money goes to the National Treasury. It's not even earmarked for the Department of Labor and Employment. We have no access to the money. So even if we charge the establishment 10 million pesos, it goes to the National Treasury. So it's the dole does not earn from this. So we do not want to provide penalty. What we're after is the workers to be recognized as part of someone of the workforce that is contributing to the society. I think there's, okay, that's last slide. So our ways forward would be, we always work within our mandate, of course. We have to ensure that the workers are not discriminated against due to viral hepatitis status. So this is also aligned to the law on cancer, as what was discussed by Dr. Cairo. We did not release a department order on cancer in the workplace. It's because we think that that is an overkill. Because every time that a disease has a law and we come up with the department order, it reduces the value of the other diseases. Because like for COVID-19, we cannot have it specifically just for COVID-19. How about for COVID-23, COVID-20? I'm not hoping that we have another COVID, but it's something that we should already be there, should be incorporated into the protection of the workers. And then, of course, we continuously advocate for the implementation of DOLE Department Advisory 5 series of 2010. But again, this is an advisory and not an order. And you have to impress upon employers, especially in the food manufacturing and handling industry, that hepatitis B is not a food safety issue. It was mentioned a while ago that some employers or some agencies are already asking that their workers be tested for hepatitis B because they are going into a canning facility, because their workers are going to be handling food, but they're not looking at hepatitis A. Then that would mean that they are creating these tests not because they are guided, but because it seems to be normal. And we do not want to normalize something that is wrong in its very nature. And then, of course, we have to continuously dialogue with stakeholders on implementing the correct OSH knowledge for all the infectious diseases, and not just once the department orders and advisories. Also, we have been in contact with the Yellow Warriors, and we have also advised them that aside from the DOL, you also have to approach the Department of Migrant Workers, the newly created Department of Migrant Workers, because as what Dr. Edel mentioned a while ago, OFWs cannot leave the country or cannot go to the country that they want to go to, primarily because it's being tested. So maybe it can be incorporated into future agreements with receiving countries on how much restrictions should be applied to our Filipino workers. Thank you very much for listening.
Thank you, Dr. Felix Labanda Jr. You know, Dole has been a partner since Yellow Wars started in 2010, no? And every year, your department has been a guest speaker, you know, and we're really a little bit sad because we are a little bit tied with the advisory note. But let me also show you a positive side of that advisory, but also a very challenging decision, or a how a judge would read through the medical records of a patient and decide on a case. So can you put a second last slide na lang. Okay. Okay, in the interest of time, I'll just discuss this in a short. So this was the first case that we handled, no, pro bono, by Attorney Eric Ueda, one of our officers, no. So the story of this was the cook was an employee already. So he was employed for several years, and suddenly, even though the employer was really aware that he already has hepatitis B, he was dismissed from work, you know. So in 2006, in October 2016, he was terminated, and because of the long court process, the case was settled in February 27, 2020. The case was already raffled to the Court of Appeals, but from that time, the company didn't want to file the case through the Supreme Court. But if you will notice, on the 2019, the case was decided against the complainant. So we lost the case. And I would just like to read the reason of a judge. Okay, so the first reason of a judge was that the medical certificates presented by the complainant himself showed that he suffered a disease, hepatitis B, since 2008, and the same has not been cured up to 2016, for more or less 8 years, even with proper medical care. And of course, we know that hepatitis B is a chronic disease. If you have been positive for more than 6 months, it is more likely that you will be having it for a lifetime. The second reason that the judge decided in favor of the company was that the respondent corporation is in the food business, which is imbued with public interest. Hygiene and sanitation are the foremost considerations in setting up and managing a food service business. In the exercise of its management prerogative, it must have a free hand on deciding whether it could consume the high risk in the continued employment of the complainant. It is pointed out that while all the medical certificates issued by the complainant appointed doctor, a gastroenterologist from 2008 to 2016, certified that the complainant was fit to work, it was never certified that the complainant's illness was not contagious. Meanwhile, in August 2016, it was certified that the complainant's illness was not contagious at the time of examination and a referral to a gastroenterologist was suggested. Impliedly, the certification meant that at any time after examination, complainant's illness could be contagious. And in October 2018, the complainant was notified in writing of his termination, there being no guarantee that his illness was not contagious. And October 2016, the medical certificate issued by the complainant doctor that the illness of complainant posed no particular risk of transmitting Hep B as a non-healthcare worker is thus deemed an afterthought. This arbitration branch also takes judicial notice that Hep B could be transmitted through blood contact as stated by a gastroenterologist. A chef, hepatitis B could be easily transmitted when complainants get cuts by knives. Blood left on knives or work surfaces could infect co-workers. And lastly, the third reason was that it could not be concluded that the complainant was discriminated against due to his illness. The fact that the respondent kept the employment of the complainant for 8 years after the latter was diagnosed with hepatitis B proved this. So, even though we already attached the Dole Advisory number 5, we also attach views of gastroenterologists and hepatologists. We lost this case because of the way the judge thought or decided on the case. So it is really, if a judge thinks that way, what more HR practitioners would think. But on 2020, at last the Court of Appeals decided in favor of the complainant was just only because they said that the Dole Advisory number 5 was in place and it should be followed. So that was the reason why we won the case. But it was really very challenging, because we had to refile the case and it took 3 years. And we would not know if the case would have reached the Supreme Court if we would have still won the case. So it really differs now from judge to judge on how they read the case, even though we attach the experts' opinion on this case. So I would like to give again to Ms. Reyna so she can brief Congresswoman Dr. Anna York on the situation on why we really need an anti-discrimination bill that would prohibit screening for pre-employment or post-employment purposes. So right now we'd just like to have a short discussion in maybe around 5 to 10 minutes. We'd like to, and we have invited Jem Cabreros from the AIDS Society Philippines. Would you like to comment on the story or anything that you can share?
Yeah, hi. Good evening, everyone. I'm Jem Cabreros of the AIDS Society of the Philippines. Dr. Cairo, Dr. Labanda, Chris, Patrick, thank you for inviting me here to the conference. Okay, so I'm a person living with HIV for 12 years now. So I'm 55 years old. I'm already undetectable. So I can empathize with the discrimination felt by Hep B and Hep C patients, because that's also what we persons living with HIV also experience. So I'll just give you a brief history of how the law came to be. So there was the first law, Republic Act 8504, which was the Philippine AIDS Prevention and Control Act of 1998. Okay. It was pushed, or the passage of that law was pushed by the late Sarah Jane Salazar. I don't know if you guys know who she is. She was the second Filipino to go public about her HIV status. So thanks to her, the law was passed. And then but after that, since there were already increasing cases of discrimination against persons living with HIV, as early as 2015, there were already efforts to amend the law, to update the law, because 8504 was already outdated. Firstly, there was no reintegration of OFWs who are sent to the who are deported to the country because of their HIV status. There was no cyberbullying law, the testing of minors. There was no provision about it yet. So health advocates gathered together. They gathered also stories from persons living with HIV, and decided to draft, which is now Republic Act 11166, which is the Philippine HIV and AIDS Policy Act of 2018. So when it was presented to the House of Representatives, it was presented to then Congresswoman Kaka Bag-aw. She was with the Dinagat Islands governor. That was her last position. And then with Risa Hontiveros, Senator Risa Hontiveros. So both of them authored the law from the House and from the Senate. And during the deliberations, the Network to Stop AIDS Philippines, which is the umbrella network of all HIV prevention and awareness groups, lobbied for the passage of the law. They attended the public hearings. They actively pushed for the passage of the law. And then finally, on, let me just check my notes here. It was on October 18, 2018, that the law was approved by Congress. It was signed into law by President Duterte on December 20, 2018, and then the implementing rules and regulations were approved by the PNAC, the Philippine National AIDS Council, on July 12, 2019. So I would really understand where the discrimination comes from and how you feel about it, because that's what we also feel for a person living with HIV. And I really welcome and I thank those who have gone before me for pushing for the passage of the law. So yun, that's the brief history that I can give about those two laws. By the way, RA 11166 had repealed the old law, 8504. So wala na siya. So it was already repealed. It was already replaced by the new law, RA 11166, which is still existing up to now. The main reason for coming up with that law is to update or come up with a law that would suit the times. So that's the reason why it was passed. Thank you.
Thank you, Sir Jem. So I think that really shows that we really need people living with viral hepatitis, or we really need to lobby or have our voices heard outside this room. And before we started this roundtable discussion, actually we talked already with Congresswoman Anna York, and she promised that she would study the bill and file it in the Congress and would maybe seek a Senate counterpart. So that's why she sent Ms. Reina Zuniga to listen, because she has a meeting right now. So we just like to ask Ms. Reina if she needs to ask something to be or to clarify something? Is Miss Reina still around? Miss Reina? Okay, maybe we can anybody in the or who was online who wants to raise a question to Dr. Bellimac or to anybody in this table? Okay, so maybe we are very clear on the discrimination issue, and we will continue to push forward our advocacy. Maybe on for Gerard Bellimac, Doc, we would just like that, since already saw the transition from the program to the life stage of viral hepatitis. I think the main challenge now is how to get the LGUs to own the program. So do you have any ideas on how we can help you push LGUs to have their own program? Because up to now, I think we have not added. I think one LGU was supposed to have their own program, but they discontinued it during COVID. Do you have any suggestions so we can help you? Now we can hear.
Great. Thank you, Chris. No? I think my response will just be based on practical scenarios, no? Where some LGUs have already have already forwarded their response to discrimination, and we know that there are LGUs na medyo advanced na in terms of anti-discrimination ordinances. Perhaps the Yellow Warrior Society and its entire membership can look into how we can incorporate provisions in these anti-discrimination ordinances by the LGUs. Of course, I think the body here in this call know better which LGUs are those, no? And they are naman high profile LGUs, so they're easy to locate or identify later on. But what I'm trying to point at also is, and it's good that a friend from the AIDS Society of the Philippines is here, is when we organize people to really have one voice to lobby at the LGU level, no? So making sure that that there is meaningful engagement of the key populations, and that they are really fully equipped and capable of doing the lobbying work, because the lobbying work is a difficult thing din, and we do not want to field advocates in the ground na medyo hilaw din yung lobbying power. So that's what I gather from my experience in working with HIV as well. So we really need to start from our respective homes, meaning to say, I suggest that we need to empower first also the membership so that they'd be effective advocates. Of course, this is not an overnight event for the affected populations, and it's difficult, but what anong makikita natin sa ngayon, that we have good models to follow. And if I could just suggest as a second thought, if you could strengthen your partnership with, for example, AIDS Society of the Philippines, who is here in the call, so that we can also learn from them on their not so nice and painful experiences in the past. Now, AIDS Society of the Philippines is not ASPS today, if not because of the difficulties also in the past. Now, so yun, number one, empower the membership so that we become effective lobbyists. And second is study the models of anti-discrimination ordinances at the LGUs. No? Yun lang, 2 points from my end, Chris. Thank you.
Thank you, Dr. Jen Belmap, for your suggestion, and we will surely take time and re-strategize after this. So I would like to thank you all for your inputs and insights. Moving forward, I hope that all of you will support whatever steps that Yellow Warrior Society Philippines will be taking in pushing this legislative agenda forward. We cannot do this alone, and we will be needing your expertise when the time comes. We also hope that the devolution of our healthcare would hasten the implementation of viral hepatitis treatment nationwide, as we have seen the challenges of implementing it since 2019. Working with local government units is already in our agenda, and hopefully they will see the need to implement a viral hepatitis program for their constituents. Again, thank you, and we'll just have a photo op before we go. Fine? We can do it. So we just stand there on the screen? Oh. Thank you very much. Thank you to all those who are online.
Thank you, Chris.
Thank
Congratulations.
you, Chris.
Thank you, Chris. Thank you, Doc Bellimac, Dr. Cairo. Cams. Good night.
Good night.
Bye. Thank you.
Thanks, Jessica. Thanks, Cynthia.
Thanks, Jessica. Nice meeting you.
Nice to meet you too. Thanks all. Bye.